Great, good afternoon, everyone. We're back in the House Healthcare Committee. So this afternoon, we'll, from 1 to 1:30, we have on the schedule the Vermont's free and referral clinics, which are a very important safety net in our communities. And then at 1:30, we'll move to the DVHA, Department of Vermont Health Access, proposed budget adjustment before we go to the floor at 3. So we have Daniel Barlow and Olivia Sharrow. Did I say that right? Please come up.
I don't, whatever, which one you want.
When the time comes.
Okay.
Welcome. We have quite a few new committee members, so we're going to go around and do introductions, and then I'll turn it over to the both of you. Does that work? Great. We're going to start with Bobby, who's on the screen.
I love how you mix it.
I do mix it up.
Hi, I'm Bobby Parley-Rubio from Caledonia One, representing Barnet, Reigate, and Waterford.
Joe Andriano, I represent Orwell, Shoreham, Whiting, Sudbury, and Hubbardton.
Alan DeMar, representing Enosburg and Montgomery.
Alyssa Black, I represent Northern Essex.
Lori Houghton, City of Essex Junction.
And Topham McFawn, and I represent Barrytown and the part of Williamstown.
Laurie Cordes, Lincoln, Bristol, Moncton, and Starksboro.
Leslie Goldman from Wyndham 3, Rockingham, Westminster and Brookline, and the Bells Falls area, south. No.
Yeah. Art Peterson, Rutland District 2, Clarendon, Wallingford, West Rutland, Rutland.
Great. And Davey?
Casey Professor from Winooski.
Great, wonderful. So I believe you're talking, right? There's no slides to wrap it up, so we'll just pay attention to you. And I'm going to have you go through and then open it up for questions. Does that work?
That's
great. Great.
And do I need to say my name?
Yes. Yes. Record and just give us a little background. That'd be
So my name, for the record, my name is Olivia Sharrow. I'm the executive director of Vermont's Free and Referral Clinics, and I'm in Berry City.
Great.
And for the record, Dan Barlow, executive director of the People's Health and Wellness Clinic in Berry.
Great. All right. So I will go first.
Wonderful.
So founded in 1995, Vermont's Free and Referral Clinics, formerly known as the Coalition of Clinics for the Uninsured, is a nonprofit association of which the 9 healthcare clinics across the state of Vermont that provide free services are members. Both our history and our mission are rooted in reducing barriers that people in Vermont experience when trying to access care. Our clinics serve as entry points into the larger healthcare system. They also serve as safety nets, which Representative Houghton mentioned, sometimes as primary care practices, and also as a critical point of care for marginalized populations. I'll talk a little bit about our services. It's important to note here that the 9 clinics are independent of each other. They're separate organizations. So the services range across clinics. They're not identical from clinic to clinic, but as I am the executive director of the association, I'm speaking broadly about the group as a whole. So again, broadly, they offer free clinical services, mental health, dental, and medical, also free medications, care coordination, case management, referrals into patient-centered medical homes, and also into specialty services. They also do a lot with insurance enrollment and eligibility, both with state-based programs, Medicaid, Vermont Health Connect, and also federal programs such as Medicare. And they do a lot working with patients accessing patient financial assistance at our local hospitals. Our funding, we're primarily funded through a legislative appropriation, which comes to us as a grant. It's managed by the Department of Health. And from 2018 until last year, we were level funded. We received just over $1 million. Last year, our grant was generously increased by 10%. And so last year, and we're hoping this year, we received a little over 1.1 million, and the exact numbers are in the written testimony. We leverage this funding in a lot of different ways, including saving the state $3.9 million in avoided emergency room costs. Those are 2021 numbers. We're in the process of compiling 2022. So using those numbers, for every dollar provided to us by the legislature for our work, we save the state $4. Next, I'll talk about our services in numbers. In 2022, we cared for 11,538 patients, which was an increase from 2021 of about 1,500 people. Of those, 4,385 were new, meaning they'd never sought care at any of our clinics in the past. And that number has increased pretty steadily. Our new patient numbers have increased over the last 5 years. So we're still reaching new people. Folks in our communities are still finding the need to seek care at the free clinics. We haven't reached saturation in the towns that we serve. We provided 41,000 instances of patient support. That averages about 4 services per patient, which is also an increase from previous years. It was about 3 services per patient. And overall, this is provided by 32 paid staff, again, across the 9 clinics. And 269, and I think I left this off the written testimony, 269 volunteer clinical providers and clinical support staff. That's really important. The vast majority of all of our services are provided by volunteers, donating time valued at nearly $500,000. And I'll make a little side note that we think that that's an underestimate. The clinics are free. We don't accept insurance. I get that question a lot, but do you bill insurance? What about Medicaid? No insurance. We don't bill per service. There's no per member per month contract. As I'm sure you can imagine, this presents some challenges. There's a limit to our funding. We have a ceiling. We can't just increase it outside of the appropriations process as we see more and more new patients. However, this does give us some freedom. And the independence in this structure in a lot of ways means that the clinics can be really pretty nimble in terms of shifting services or programs to meet the needs in their communities. One example of this is from a clinic in the southern part of the state where one of the local Planned Parenthood clinics closed over the summer. There were 5 across the state of Vermont. And in just a couple of months, the clinic was able to create a reproductive health program to meet the need, to meet the gap that was left by that closure. So I've focused on the good stuff, and there's a lot. I can't overstate the passion of staff and volunteers. They're doing incredible work. The quality of care is incredible. We hear that from patients over and over again. But at the same time, it's important to note that we are seeing some concerning trends across our clinics among our patients. 43% of patients are currently underinsured, and we saw that number increase pretty significantly from 2021 to 2022. It was 35% in 2021. We also expect those numbers to increase as Medicaid continuous coverage ends and Medicaid closures begin. Our patient numbers increase. 26% of patients arrive at our clinics reporting having delayed care, both due to cost and or difficulty getting in at other practices, local practices not accepting new patients. They couldn't get an appointment. And overall, ongoing and in many cases increasing challenges accessing dental care and dentures, and also mental health services. To finish, there are 2 takeaways that I hope I can leave you all with as you think about your work for the next 2 years, and also as you think about how VFRC fits into the state's broader healthcare system. One, our patient numbers can seem small, especially when you compare them to a hospital system. But I hope it's been clear through what I talk about, what Dan talks about, that we're seeing patients with some of the most complex needs and with patients who are experiencing some of the highest barriers accessing care in our state. I also hope I make this clear that data from what we're seeing at our clinics can provide really valuable insight in terms of the health of the system overall, acting as sort of signals of what we're seeing, like I talked about, underinsured numbers rising, new patient numbers rising, patients overall rising, and really illuminate the experience of those at the margins. And I hope that encourages us all to think about our work and what we're doing in the state.
All right, so we'll do a couple questions before we get Mari and then Alyssa.
Thank you for that. Can you repeat the numbers you gave for differences between visits last year and this year?
Overall,
Yeah.
it was, let's see, 11,538, and last year it was 10,128, so almost 1,500. Yeah.
I wondered if you had a sense of how many patients that you're seeing are either new Americans, some sort of immigration status, legal and undocumented.
Yeah, that's a great question. So we have a shared patient database, and we do track race and ethnicity. We don't track language. One clinic in particular in Addison County, and did somebody here say they were from?
Yeah.
Yes, yeah.
Oh, and Mari, right?
Oh, yep, I was gonna say, I
Volunteer.
thought I heard a couple towns. Yeah, so the Open Door Clinic is one of our members, and I believe it's about half of their patient population is from the migrant worker community, does not have legal immigration status. And so that, when I talk about the clinics sometimes act as primary care providers, for the most part, patients come in, they get assistance with insurance, they get help with free medication, they have sort of primary care services, but the goal is to move them to an ongoing patient-centered medical home. They may get imaging, specialty services, but in communities and among patients for whom immigration status bars them from ever having access to any kind of insurance ever, the free clinic in that community really operates as a primary care, their primary care provider, providing services and also a whole range of sort of assistance in accessing other services outside of the clinic, either at the hospital or arranging transportation, providing translation services and things like that.
That was follow-up of with such a small budget. How on earth are you able to provide translation services?
Oh,
I know how much those cost.
It's tough, and they've done a pretty amazing job finding staff who are bilingual, both in the community that they serve, and then also just people with language skills within that area. I will say mental health is a huge issue. Finding providers that are bilingual, it's mostly Spanish. That's a big problem. And finding, I was just talking to the director of that clinic yesterday, volunteer mental health providers are a huge challenge. It's hard enough to find mental health providers that you can pay, and that's really tough, and it's a big barrier for them.
And just thank you for your service, because you're a wonderful resource, underappreciated.
Yeah. We're gonna go with Leslie and then Joe, and then we really want Daniel to have his time.
I was just looking at your, and all the data and everything, but you also mentioned increasing complex social determinants of health. And I was wondering if you could speak to that, like which ones are you thinking about? If you had a magic wand, what would you do?
Well, housing, healthcare.
We haven't heard that.
I would imagine that nothing that I would say would be different from what you've heard, either talking with constituents or other folks that have come in to give testimony. What I'm hearing from the directors of clinics is that in addition to just a need for services, and I can't stress enough the, I call them the bottleneck issues with patients finding another practice, to whether it's dental or primary care, just getting into those practices. And the longer it takes for them to get into the practices, the longer they're receiving care at the free clinics. So that's that piece. But in addition to that, issues with childcare and housing and transportation. And I think Dan can probably speak to this a little bit more, because it's the executive director of People's Health and Wellness. They're really on the ground. But just a range, food is another huge issue. And I think I might mention it in the written testimony, that the clinics provide a range of food services, whether a pantry, a food shelf. One of them provides a home cooked hot meal on clinic days. So that's a little bit, but I want to turn it over to you.
Joe, do you want to go and is it?
You mentioned that the appropriation is your funding. Do you seek any grant funding, or you just go with what the legislature appropriates to you?
These are great questions. Let me arrange my thoughts. The legislative appropriation is our biggest grant. We also do participate in the tobacco cessation work that the Department of Health does, and also the You First program, which is breast and cervical cancer screening. So those are two other grants that I manage. Each individual clinic does pursue its own funding, whether through town appropriations, individual giving, foundations, and also other grant programs. But the role of VFRC as the state association and overseeing those three grants, I really manage the grants that everybody or that a majority of the clinics get money from, and those come to me and then I distribute them among the clinics. The question about whether we pursue more and how and when is something that we're actively discussing now. So it's a great question.
Thank you.
Yeah.
Thanks. So I want to echo everything Olivia said, especially about the kind of canaries in the coal mine of the system breaking that we're seeing. So People's Health and Wellness Clinic is a small free healthcare clinic in downtown Barrie. We've been in operation for almost 30 years. We're a very small staff, 6 employees, about 3.5 full-time jobs there. And much of the care is provided by a roster of about 40 volunteer doctors and nurses who come in once or twice a month to see patients. We also have a nurse practitioner on staff who's our director of clinical services and a part-time dental hygienist. And I'll talk about our dental program a little bit because I think that's really where we're seeing some incredible growth and demand and some real needs as well. So to your question, Representative, for us, our budget is about $420,000 a year. So the Vermont Department of Health grant is about a quarter of our total funding. So I do spend, as executive director, a lot of my time fundraising for the clinic, corporate grants, individual donations, and municipal funding. So it's a big part of the job is we're a charity, like a lot of charities, we have to look for resources to do our work. And we're also seeing the same growth that some of the other clinics are seeing in demand for our services. So just last year, we saw 408 patients, distinct patients, and 159 of them were brand new to the clinic, first time. And ideally, the pipeline that the model that we have is that someone comes into the clinic, we get them in to see a primary care doctor, and then they move over to our community resource specialist, and that individual helps them find a primary care provider, helps them sign up for health insurance. Unfortunately, that pipeline is breaking. Our community resource specialists cannot find primary care doctors who are accepting new patients, and especially if they're patients on Medicaid. It's become a real problem. So that pipeline is broken for us at this point. We're having fewer and fewer successes. We're getting people on health insurance, whether it's Vermont Health Connect or Medicaid, but after that, finding them the permanent primary care home, because we are not the permanent source of primary care for them, that's becoming harder and harder. I'm often asked what's our patient profile? And I do like to say almost anyone in Vermont. I think, I think folks in this room probably have a family member or a friend or a neighbor who have used a free clinic in Vermont at one time in their life. I often hear from people that they use the free clinics, but they just lost their job and lost their health insurance, or they just moved to Vermont and they don't have a lot of resources. But for the fact is, majority of our patients are incredibly low income, incredibly vulnerable. And we are the last place they can go to get health care beside the emergency room. A little bit of data, in 2021, more than half our patients actually had health insurance, and that was a big change. Back in 2007, so about 15 years ago, 90% of our patients were uninsured, and last year more than half had health insurance, but they were coming to us because they couldn't find a primary care doctor or they couldn't afford the out-of-pocket cost for the program that they're on. And this is a symptom of a really broken system. These folks need to find a permanent home within the healthcare system, and we don't have the resources because our doctors and nurses are volunteers. Most of our patients live in poverty. Nearly a quarter of our patients make less than $14,000 a year. The vast majority are under 200% of the federal poverty level, which is about $27,000 for an individual. And as Olivia said, 1/4 of our patients tell us that they delayed care because they didn't have access to a doctor or health insurance. I want to spend a few minutes talking about our dental hygiene program, because this is relatively new for us. We added this 5 years ago. We have a part-time dental hygienist. She's there Tuesday, Wednesdays, and Thursdays. Sees 4 patients each during those days. And I spoke with her yesterday, and she's seeing at least half her patients right now are brand new to the clinic again. She had 4 patients yesterday. 2 of the patients who come in are going to need all their teeth removed because of delayed care. And the problem that my dental hygienist is also encountering now is several years ago, we had really good relationships with local dental offices, and they could take on patients, give patients discounts on root canals or extractions. Those resources are really drying up. Our friends and allies at private dental offices cannot accept new patients. They cannot afford to take on new Medicaid patients. And a big concern is it's becoming harder and harder for our patients, once they get the extractions done, to afford dentures. A decent pair of dentures, top and bottom, might cost about $2,400. My dental hygienist can get a $400 voucher from a Catholic charity. That does not bring that patient anywhere close to being able to afford those dentures. And I did promise my dental hygienist that I would mention that she really wishes that the state Medicaid program, that you could use that allocated spending to purchase a pair of dentures. And I believe there's about 10 states that do allow the state Medicaid program to do that. But right now, from her view, these are people who, the masks are coming off. They realize they cannot hide the state of their teeth behind a mask anymore. They want to get jobs. They want to be out there in public, but they know that this is a barrier to getting a good job, to being, social in the community, and they have no resources right now to once the extractions are done, to afford dentures. It's becoming a real dilemma for our patients and a real crisis. I know everyone comes to the legislature looking for funding and resources. Quite frankly, I think we are a good investment in the healthcare system. Olivia talked about what the payoffs are. And I know if we had more funding, I could add, another day or 2 for our dental hygienist. 2 more days a week for their dental hygienist is 8 more patients a week who are seeing our hygienist, getting cleanings and getting preventative care, so they don't end up in a position where they find out they need all their teeth removed.
So sad. You had a question.
I think I've forgotten my question.
Any other questions for?
Oh, I do remember.
Okay.
I'm sorry. I started going back to, I remember because I'd worked on a bill 2 years ago, and I was surprised to learn that pediatric patients are not seen. And I'm assuming that's because of the volunteer providers, the specialty of the volunteer providers. Is that still the case, or are any of the clinics seeing pediatric patients?
So I believe, so let me see if I can explain this, because this gets into the intricacies of how the clinics are insured. And Free Clinic, you probably know the answer to this. It's an FTCA issue, right? Do you want to actually?
I think my understanding is that we get federal malpractice insurance coverage from the federal government, which does allow our volunteers to do their volunteer work in the clinic, and actually allows us to do things like go out to local motels and hotels and meet with the homeless population and bring care directly to them. My understanding is that that's a barrier for us there. So, yeah.
And I'm assuming with the new reproductive health clinic that you have, that you're probably not able for the same reason to provide obstetrical services?
For younger teens, basically, that's correct.
Okay.
Art?
Your question just now, I wanted to follow up on that. What type of reproductive services do you offer?
Oh, this is a good question. And it's new, and it's because it's a program at the clinic. It's not one that I directly oversee.
Okay.
So it's rather than try to remember / guess, why don't I ask and I can follow up with you.
Okay.
I know for us, we don't offer those services in-house, but we have a relationship with the local Planned Parenthood in Barry.
And that was the case in areas where those clinics close, where there is a free clinic and there's a Planned Parenthood. Same with the hospital, same sometimes with the FQHCs. The free clinics develop close relationships with those other providers. And so that, that was part of what happened when that clinic closed, was there was a loss of the, I think, for example, STI testing and things like that, and just reproductive information and contraception and things like that. But specific services, I would need to check.
That's fine.
Yeah.
You've answered the question. Thank you.
Great.
Thank you. Thank you both. Thanks to all the volunteers and staff that you have. It is a service that we need. And you're right. I think it needs to be elevated within our healthcare system. So thank you both. Keep in touch.
Thank you. I appreciate this opportunity, but sometimes folks don't know about the system of free clinics or confuse us with other parts of the healthcare system. So we really appreciate the ability to illuminate what we do.
Alan?
So how do you get new patients? Somebody refers to you?
We advertise word of mouth as well. I know for us, the local newspaper did a big article about us last month, and we got lots of new patients and luckily some new donors because of that as well. But it's we don't have a problem finding new patients, and they don't have a problem finding us, it seems.
Thanks for your work.
Thank you.
Thank you.
No, thank you.
Thank you.
Great. We are going to maybe take a few seconds break till the commissioner arrives. She's outside. Just remember, we're still on air, everyone.
Yeah.
Help me.
Can't reach you from here.
I don't know, but I can try.
What are you trying to get? Oranges?
I'm going to keep trying.
Oh, pen. There you go. There you go. I'm going to the house calendar, and there are all these things.
We'll make sure you don't walk out with that.
And I'm not finding, I can't find out how to get the actual language of the.
Nice.
Okay.
A true heart.
Hello.
Hi.
Hi, welcome back. You all again. Patrick, do you wanna, where do you wanna be?
Where's the
Do
setup
you wanna be in the
spot?
middle? This is the,
This is the
yeah,
hot
if you
seat.
have the laptop, you
Yep.
probably should drive. Better for me to be on this side or this side? I am left-handed.
No one's sitting there
Oh,
today,
then I'll stay.
so it's probably.
That's
more
probably the
comfortable.
best.
So I want to make sure everyone has the documents. We did go through the DMH budget yesterday, so there's some general understanding of how the budget process works. But remember, we're all pretty new to this. So I have not looked to see what's online. You'll be able to share it, correct?
Yes.
Okay.
I think probably will be permissions to share your screen when you get there.
Do we have talking points? Let's see what we have here.
You put together a narrative. Perfect. Which really helps with the line items that match with the budget line items.
Oh, great, okay, yes.
Yep, I'll do a brief overview of
Wonderful.
all of that for folks.
This is actually, I do think, I'm gonna give Diva some accolades here. You're the best.
Oh.
Yeah. Oh, whoops, I forgot we're on air.
Thank you.
Yeah.
Steve does a great job.
So for everyone, if you can look on, if you want, the screen will be up, but also it's under today's date, under the commissioner's name on our committee page.
Turn it over to you.
Are we going under, Commissioner said something and Patrick sent something. Oh, I just.
Nice. Look at that.
I'm sorry.
Did a job on my computer. It's all messed up now. I don't know.
No. And I don't know how to fix it.
I don't either.
Are we going under your name, Commissioner, or Patrick? Who sent in the documents that we should be looking at?
I think it came from Jess.
Yeah, so you can put it under me, it's fine. Jess is our admin that she helps keep us on track.
Something with the commissioner's name under a.
So it's the budget adjustment narrative versus the other piece.
Correct.
Okay.
The one that was updated, I believe it was yesterday.
So the top one. Yeah.
Perfect. The same as you presented in the first.
There are just a couple of slight narrative, like text changes. We just updated it to be more clear. Oops, sorry. The money didn't change, but just a couple of the words. And then before you share, I'll just do a brief intro. How's that?
Sounds good.
Okay.
Get started? Great.
Great. Hello, Madam Chair. Thank you for having us today. My name is Andrea Bear, Commissioner for the Department of Vermont Health Access, for the record. Joining me today is Patrick Rooney. He's the Department of Vermont Health Access CFO. And we are happy to provide an overview of the budget adjustment for FY23. And essentially, we're requesting an additional $101.3 million in new appropriations. Similar to the last session, one of the primary drivers of this request is the increased Medicaid caseload utilization due to the increased enrollment in Medicaid members throughout the public health emergency. So I think it's probably best here if I turn it over to Patrick to walk you through the narrative, which they're looking at the narrative, I think, Patrick.
Oh, okay.
And answer questions as we go along.
That'd be great. And we have until 2:45, if you all have until then, to make sure we
absolutely
use the time. Great. And real quick, I want to introduce Representative Woody Page, who is joining us, who we're all happy to have in the room.
My eye
You come sit here.
Yeah, he's over there because that's where you were, all of us.
Representative Page used to be on the healthcare committee. He has moved up and gone to House Appropriations and has the DIVA portfolio. So you're a party to this conversation. If you have any questions, just raise your hand, please. Great.
Okay, good afternoon, folks. Pleasure to be here today. For the record, I am Patrick Rooney. I am the head of the finance team at the Department of Vermont Health Access. I'm going to give a brief overview here for you. As we know, several members are new. I'll start with what's known collectively as the ups downs document. Here at the top, you have your fund sources and uses, starting on the left with general fund and moving to right, concluding with investment global commitment fund and aggregating in a total on the far right-hand side. The Department of Vermont Health Access has 4 appropriations. That's B306, B307, B309, and B310. And you can see that within the ups downs document. It's highlighted in gray there. And those appropriations are bucketed into two. Internally, we look at it as one department, two functionalities, one being administration, which is the day-to-day business, the ops that go into carrying out all the services that we provide for Medicaid members. Then we have what we call the programmatic side, and that is B307, B309, and B310. And so as we go through the narrative, which has the context to our request before you today, we're going to have it bucketed, as you can see, in administrative and then programmatic, and we'll work through that. So within all of this.
1 second, Patrick.
Oh, sorry.
Is
Yes.
the narrative available on the website? Because I'm not seeing.
Yeah, there's the narrative is under the commissioner's name and the ups and downs is under Patrick's name.
And so within all of that activity, we have line items that are numbered. On the left-hand side here, you'll see 1, 2, 3. And what we've done within the narrative is we're following numerically in ascending order from 1 to, I believe it's 13, the line items that we have requested. And so within that narrative where you see multiple numbers, as you see 3 and 3 here, we're calling out those line items, but they're all part of one request. And so we've aggregated them in here, but we've also broken them out into tables to show you their individual components as it relates to the total for that line item. We also have some cross appropriation activity where we have a request. You may see the same item go across the programmatic side in 307, 39, and 310. We've followed the same logic there where we try to bucket it for you in those tables and show you the individual components that aggregate up to the total request. So that's kind of the logic that we're working through here with the committees as we testify. And so far, so good as far as folks being able to understand what it is we're looking for. So as the commissioner alluded to, we are here as part of our 2023 state fiscal year budget adjustment request. We're looking for essentially $5.86 million on the administrative side in gross funding authority and an additional $95.5 million on the programmatic side, gross funding authority, which sums up to the $101.3 million in gross spending capacity, in addition to the as passed budget for 2023.
I want to clarify, Patrick, for everyone, if you remember, gross, correct me if I'm wrong, means state general fund dollars and the federal match.
Correct. Yes. And so you'll see here on each one of these, we've got a gross factor and then the state fund impact factor as well.
So should we switch to the narrative now? Or?
Yes,
Okay.
I can switch to the narrative. Yep.
Okay.
I'm having a hard time.
Yeah.
Yes.
I'm having a hard time following. I'm not seeing your numbers on that sheet, so I'm not.
Let's go to the narrative.
Okay.
Narrative will be better.
Yes.
All right.
Yes.
So let's make sure everyone has the narrative in front of them.
Okay, we're on the narrative.
It's
Yep.
not the spreadsheet,
Yep.
it's the document under the commissioner's name.
Okay. So the statements I just made around high level requests here are seen in this table, starting out at the top. And the paragraph underneath that basically walks through the logic I just walked you through about how we're trying to crosswalk these items and reconcile them and show them in the aggregate, but also break them out across appropriations within each individual request, should we have that. So on the administrative side, you can see the $5.86 million gross, $4 million state fund component. There are these 3 line items that drive that overall number for the administrative side. Transitional housing complex case management. This is essentially a gross net neutral transaction. What we're doing is we're backfilling federal funding that we're losing that has been provided for this effort historically, and we're requesting Vermont state fund, general fund to pick up that slack. So in the ups downs, you're going to see a negative 200,000, and then in general fund, you'll see a positive 200,000. So the gross effect is 0. The state fund impact is $200,000.
Sorry to interrupt you again. Would you mind putting up the narrative on the screen so that as you talk, we can make sure we follow?
New share, sorry. We don't use Zoom. I'm assuming as I switch documents, we are.
Yeah, no, we've noticed that with others too. So, okay, so just we're all.
Okay, there we are.
Wonderful.
So you can see here in the gray, this is the administrative side. I apologize for that.
No, that's.
And the gross request for the administrative appropriation and the state impact. And we followed that breakout down through each one of these line items. So the line item I just reviewed, number 1, the transitional housing complex care management. As I said, estimated backfill for the loss of federal funding that has been provided throughout the public health emergency that is no longer going to be available to us, and we're seeking a general fund backfill for that effort to redeploy the Vermont Chronic Care Initiative staff to the transitional housing case management. Number 2 is the Agency of Digital Services Service Level Agreement, or SLA, as we refer to it. All departments and agencies in the state of Vermont utilize ADS for their IT and technological needs, and therefore we all contribute to that agency's budget to help facilitate all the work that they do for us, including how we're making this happen here today. We have an added cost component to that we're here to request, and that number is $64,752. Next item up is the Medicaid Data Warehouse and Analytics Solution, also known as MDWAS. This is an effort being undertaken by the state of Vermont to construct a centralized data repository with robust reporting and analytics tools. It contains all Medicaid-related claims and clinical data. We currently don't have this capacity in the state of Vermont, and this project is the next step in the strategy to modernize the Medicaid Management Information System, otherwise known as MMIS.
Can I ask a question here? So how is this different from the clinical data or the claims data that we have within Vermont? So this is a whole different database.
So this will be, would you like to take this?
Nope, you can take this.
VCures, right. So VCures, I guess, is what I'm.
Right, so that is actually governed by the Green Mountain Care Board. And the Medicaid claims hub, if you want to call it that, or repository lives at DEVA through a vendor that procures our claims. We don't actually have a central repository, which is what the goal of this project would be, where you have claims data where you only have a limited amount of information available to you, and clinical data where there's a completely different kind of available information, and putting those together is probably the pinnacle of where you could be in terms of having the information you need to make good decisions for providing care. So that's the goal. We're not there yet. It's very disparate. VCures is one database. We've got another one with Gainwell, which is our claims processing agent. This is an effort to kind of kick this off in a more modern.
So is this a new project being asked to be funded here, or something that's been worked on and you're asking for additional funding?
So this is carry forward. So this has been in progress for a little while now. And these funds would be to support where we are today. We're still under many contract negotiations for the next phase, but then whatever money wouldn't be spent during this carry forward would be spent in FY24. That makes sense.
And was this, sorry, I'm just gonna ask a couple more. And was this, I'm trying to remember back to past budgets. Did this used to be called something else that?
I can't speak to that. I don't believe so, but we can, let me just confirm that. I think this is a different effort. It may sound
similar, but a different effort. And I guess the key I want to make is that this 5.8 million, this is not I'm going to ask again, this is not a new project you are kicking off the ground. It is a project that you've been working on, and additional funding is needed to continue it.
So there are parts of this project that have been in progress, absolutely. And then tomorrow you'll find out more formally what's in the next budget. We can't speak to it. There will be another phase, but contract negotiations are underway right now.
To that point, was there any money in the budget last year for this? Was it not appropriated in the budget last year or at FY23?
We have had, can you speak to the background on, we have had, because there is a 90-10 match in the funding, we have had these ongoing improvements happening last year, and it was funded. I think this is more of a new effort, and I'm going to have to go back and find out. So we have resources that are in the central office that are closer tied to this project. But my understanding is that we have had a phase of this project throughout FY23. And then The additional money is because of a change in contracts.
So if you could provide if you could provide the information that might have been in the past budget.
Sure.
Just for history's sake, that would be very helpful. Art, and then Joe.
Yeah, I guess my question kind of follows up here. This wasn't anticipated when we built our budget last year,
The additional monies.
Yeah, I mean,
Carry forward.
$3.8 million is a lot of money, and I wondered if it was ever anticipated, so we could have put it in the
The
budget.
overage, I believe that the MV it's a different acronym, so that the acronym is new. And the contract amounts did absolutely change unexpectedly.
Wonder why we started this if we didn't have the money for it.
So this money, as you can see, is a carry forward. This is coming from the appropriation 301 from the central office to DEVA. And it's going to be the source of our match moving forward. So we can follow up with the central office and get some more background for it.
Can you just describe what you mean by carry forward?
It is money that was left over from 2022 state fiscal year. And they reserved it. I believe they probably knew something like this was going to happen. And so they've asked us to put it within our budget to facilitate that work.
So it's not new money, it's money that's already sitting there.
Correct. Yep.
Joe?
That might have answered my question, but I want to ask it anyway because I'm very new to this. On the up downs for section B 306, what is designated as grants 3, it says AHS net neutral. And so is that what you're talking about here? That it is not new dollars, it's already appropriated dollars, you're just moving it basically from bucket A to bucket B because some language change? Am I understanding that properly?
So that's essentially exactly what's happened. From the purposes of the AHS agency-wide budget, it is net neutral. They are taking it from their appropriation and moving it to ours to pay for the cost of this work.
Got it.
Yep. And I should also note too, and this is our mistake, but we wanted to bring it out front here because it was too late to change it. We often use contracts and grants synonymously within DEVA. These are not grants, these are contracts. And so as part of our request, we would ask that the various committees authorize us to move that up under personal services. So it's misallocated under that grant section. So I wanted to make that clear to this group here, that would have to be part of any approval for this request.
Okay.
Then we can shift it within our budgeting system with that approval.
And you just send us a reminder of that.
Absolutely. Yep. I've been doing it. I've got some stacked language for.
Okay, great. Topper has a question?
And I want to make sure that what you asked, are you going to tell us where that money was supposed to be spent and it wasn't spent?
So you're saying it's a carry forward from money you had allocated. What was it allocated for?
Oh, I do not know because it comes out of central office, so we can follow up.
That would be great.
Okay.
Leslie?
So you make a distinction between contracts and grants. So can you make that distinction or like what do you want me to know about that? What do I need to know?
We didn't allocate it on this sheet correctly.
No, I'm just asking about what do you mean the difference between contract and grant?
Oh, boy.
Okay, never mind then.
Yes.
Maybe on the back end.
Yeah. I think I can find that. So I'll make a note to follow up with that.
Thank you.
So that rounds out the administrative portion of the budget. Do you have any more questions before we move into the meat of it?
Just really quickly, back on that, just to be clear, this is a conceptual design. We're not actually doing this now. This is just what we'd like to move to, and this is for developing that software.
So I would say that some of the work is in progress, has been in progress. This is not a brand new project, like conceptual project. A lot of the work that so the Medicaid Management Information System is our, if you want to call it a repository, it's a loose term. But we know that platform is quite old. And we know that we have to do things to modernize it in order to make it happen. And that work has been happening.
Yeah, I think what would be helpful with so many new people is, I do believe this has been in past budgets. If you could just provide some of that information, that would be
happy to do that.
Great. So yes, we can move on. Oh, sorry, Leslie.
Well, that's just why I wanted the distinction between contracts and grants. We do have a lot of new people here who may not.
Absolutely.
Sure.
All right, program.
Okay. So as stated, the programmatic side of the house is the cost we incur for providing for our Medicaid members. And you can see here that $95.5 million in gross is the request. So 95.5 out of the 101.3 is a significant amount of money. And it's largely being driven by item number 4 here, caseload and utilization changes. So DIVA collaborates with Joint Fiscal Office, Finance and Management, and AHS Central Office to go through a process called consensus, where we try to model and predict what our caseload will be for the coming year, and we build that into our budgets. So as I'm sure you're aware, the public health emergency has had a lot of shifting components to it. There's, it's every other month or so, we're waiting on the federal government to let us know when the public health emergency will end or if it's going to be extended. And so when the assumptions were built in last year, they assumed that the public health emergency would end at a certain time. It did not. It is still ongoing. It has recently been extended. And so with that, Medicaid rolls continue to be enhanced. And this goes back to the beginning of the pandemic, where enhanced federal dollars were available to states if they continued coverage to allow people to have access to health care via Medicaid. And so what that means is they haven't been undergoing what used to be an annual process of redetermination, which based on income lets people know if they are still eligible for Medicaid or not. So those people are still on our rolls. Our rolls have continued to climb. I think we're carrying 36 or 37,000 more members now than we were at the beginning of the pandemic. And so with that comes an added cost for the folks who are on the Medicaid rolls. Very recently, with the passage of the Omnibus Spending Act, they have decoupled the public health emergency from this continuous coverage and redetermination activity. And so that's going to end in April. And what's going to happen is DIVA and organizations like it around the country are going to begin to go through the Medicaid rolls and find out who is still eligible for Medicaid. So one nice component of this is originally that enhanced federal money was going to come to a cliff stop, and now they're going to phase it down as we begin to bring the Medicaid rolls down. So, however, for the balance of this fiscal year, we still have a lot more people to cover under care. And so that's what this request here is for, at just shy of $45 million. And you can see here in the table up on the screen behind me, this is one of those cross appropriation requests. So we have it in global commitment, we have it in state only, and we have it in the non-waiver component as well, which aggregates to that dollars.
Great, let's just stop there and see if there's any questions. Art?
Just a quick question. Is that on your chart?
Yes, it is.
I'm having a hard time making the numbers look the same, that's all.
So I did bring about a half dozen hard copies.
I think I have it right here.
So caseload utilization number 4, you can see the 43.8 million right there. And that leads right up top here. And then the appropriations on the next page, number 4, leads off appropriation 309 and appropriation 310. And you can see the numbers here, 1.214 million in the aggregate and negative 25.2 thousand there.
All right.
Would you get more of those?
I do, yeah, absolutely.
Is this different than the one we had?
No.
So, and I maybe for, just to confirm again, so on the, Patrick, tell me if this is wrong. On the narrative, you have numbers. So under administration, you have 1, 2, 3. That 1, 2, 3 corresponds to your 1, 2, 3 on the spreadsheet.
Yep.
So you'll see 1.
That's correct. Yep.
But the spreadsheet we got sent on the wait a minute. Operator error here. All right. Never mind.
You good? Okay.
Never mind.
Joe?
I guess, I have a question, I guess. I'm very new to this, and so I'm trying to wrap my head around it. I guess obviously this is a lot of money. I guess I'm wondering, is it and unexpected a lot? Like, is this in line with sort of what we would expect from a BAA for this particular thing? Is this shocking to people? This is more of a question for the chair, I guess, or for the committee. I just don't feel like I have context for this number to be able to understand whether this is like, well, yeah, this is what we would expect on a budget adjustment, or if this is something where this is out of line with what we've seen in the past. So that's sort of number one question or comment. Number two question or comment is that if I am reading this correctly in what we were told how to read these, the top line, which is in teal of the ups and downs, is the appropriated as part of the FY23 budget. And then you have the adjustments and it goes to the bottom line here. So there's like if I'm reading this correctly, $100 million difference in the Medicare GCF under the B307 fund. And so again, I'm just sort of wondering, because what I'm seeing here is 44 million. Okay, I see. It's in the gray box, and so I'm going to retract.
You're getting it.
I'll ask permission to retract my previous question, but
That's all confused, but as long as you're there.
I will not retract the rest of my question, which is sort of like, is this in line with expectations?
So I will say, from working on previous budgets, yes, there's always caseload and utilization changes in the BAA, without a doubt. Is this number larger? I don't know, but we expect it to be larger because of everything Patrick just went through with keeping people on Medicaid through the pandemic. So, honestly, this is, as long as we understand the numbers, this is one of these items that, quite frankly, just has to happen. Yeah.
I'm sorry, I have to ask the newbie question, even though I should get this, but the ups, downs, why is there no state? Why is it all under global commitment?
Because that on the far left, you'll see it says B307, and then just to the right in the teal says global commitment appropriation. So within this bucket, it is going to be entirely global commitment dollars.
But on your narrative, you have state.
We have several on the narrative. We have global commitment, 43.8 million, state only 1.2 million, and non-waiver negative 25.2 thousand.
Could you maybe, sorry to do this, could you pull up and just point to where you're referring? I know that's a pain with.
No, not at all. This is my first go around here too. I've been here for 10 months.
Oh, wow.
Myself through this for 3 or 4 months now.
We'll put the heat on.
Yeah.
We'll get
You are doing great.
This is, I don't know what version of the ups downs this is, but it's got to be 30 something. So I've had a few run throughs. Okay. So for the global commitment portion of caseload and utilization, you can see here, the line I just highlighted has the number 4 to it, next to it. It's $43.8 million of global commitment funding, which will align with the top line of that table in the narrative. If I scroll down to the next appropriation, state only, which is called out here, you'll see on this line, number 4, caseload and utilization, and you'll see all the way to the right, the total here is 1.214, which will tie to that gross amount in the table on the narrative. And then I'll go down to the next appropriation, which is the non-waiver 310. And on this line has the number 4 caseload and utilization. And all the way to the right has the total of 25.216 negative. So those aggregated together come to the gross appropriation of $44.9 million that we're seeking here. And they'll tie right to this table here in the gross section. The state-only section is based on the FMAP that we are provided to calculate what the state component of of a global commitment will be.
And so this chart in front of us is set to show the gross amount, not the state amount.
Correct. Yes.
Okay. Yeah, I was just looking for that 16,698.
Yeah. So you will not see that on the ups downs. That comes from an FMAP figure that is provided to us by central office, and we run a formula to see how much the state impact of that global commitment piece will be.
Okay,
All right,
I totally understand.
number 5.
Okay, number 5, I'm gonna switch back to
Oh, yes, thank you.
our narrative here. Look at me learn.
Everybody's getting hot here.
If you don't have a sense of humor, you'll cry, right?
Tell me about it. A few weekends and nights spent in front of this stuff. Okay, so next up, number 5 is Medicare buy-in and caseload changes. This is where under the federal government, we're allowed to use Medicaid dollars to buy into Medicare for those who are dual eligible to make sure that they get the maximum amount of coverage that they need. This program has been around since Medicare and Medicaid came into creation back in the 60s. There's a slight increase here. I'm sure you folks are aware, or you will become aware, Vermont's aging demographic is posing some significant cost challenges to our healthcare system. So there's a demographic shift here based on that consensus work that we did, where we've got to come in and ask for a little bit more money to support this annual effort where we buy in on behalf of Medicaid members, utilizing some of those dollars. So that gross impact, it's cross appropriation. So in the global commitment section, you're going to see a gross amount of 1.13 million. And in 310, the non-waiver section, you'll see an increase of 157,000, aggregating to $1.289 million as our total request for that.
And as with the caseload, there is always a annual Medicare buy-in and caseload changes in our budget as well.
Yep, and they're relatively consistent.
Yes.
My understanding from the most part, but as more people age onto Medicare and Medicaid, we have an enhanced need for it. Next up, I'm going to spend a little bit of time on this one because I think this is important for folks to understand. And after our testimony last week, I went and put together a quick visual to help folks understand. So graduate medical education, or GME, is a program that's been around for years. And in our specific universe here, it's an arrangement between the state, the University of Vermont, and the University of Vermont Medical Center. The University of Vermont Medical Center is the state's only academic teaching hospital. And so as part of this GME appropriation, for which we are seeking enhanced global commitment spending authority from you all, money is provided from that partnership to take money from the University of Vermont. They send us money through what they call an IGT, or intergovernmental transfer. DVA then passes that up to the federal government to enhance those dollars and then draws them back down in a larger allotment. And we pass that to the medical center to specifically train postgraduate residency people. So this money helps pay salaries for those post-residency practices. And this is essential towards training the next generation of providers. And we have a provider shortage in this state and in this country. We also know the cost of salaries, et cetera, is going up. And historically, for the last decade or so, this has been about a $30 million a year appropriation. So what you have in front of you is, using the current calculation methodology, we have the capacity to enhance that annual payment to $51 million. So what we're asking you for here is the net of that from a gross perspective of 21.2. So we're asking to enhance our global commitment spending authority and to provide the University of Vermont Medical Center, in partnership with UVM, additional dollars to train the future providers at the hospital. So I did put together a visual, as I said, to kind of help out with how this whole thing comes together here. So as I stated, the University of Vermont provides funds through this intergovernmental transfer. The state deposits them.
So we're not seeing the graphic.
Oh, that's right. I got it. That's right.
Sorry.
One step forward, 2 steps
By
back.
the end, we'll be in good shape.
Yeah, I'll get it in the last 5 minutes. Okay, so we have here on the left, the University of Vermont. We have a contract with them and the University of Vermont Medical Center, whereby the University of Vermont passes these monies through to the state. We push them up to the federal government for a gross up match. And then we pull those funds back down. And you can see by the added dollar signs here that I've finagled into this visual that we come back down with more money than what went in. And so then we pass that over to the University of Vermont Medical Center. Historically, it's been in quarterly allotments so that they can cover the cost of having these providers under residency there at the hospital. So with the workforce issues and with the cost of providing healthcare going up, we have this additional capacity to seek from you all. And it's very important that no additional general fund dollars are needed for this. Enhancing federal money and bringing it back down into the state of Vermont, and we have the capacity to do it. So I have a couple of hard copies of this visual too, if anybody would like.
Great, let's do a couple questions. So Alyssa and then
No,
Daisy.
I just, in a nutshell, UVM is gonna pay us $8 million. We take it, we do magic with it with the feds, bring it back, and then we give it. So this 8 million you're asking for, UVM is gonna reimburse us for that. Somewhere in the budget, somewhere along the line, intergovernmental transfer.
So the money starts out with the University of Vermont. Yeah, to pass it through, we move it up and it comes back down in a larger tranche. That is my,
From the college.
From the
To
college.
the state,
Yep.
back to the medical center.
And this is post-residency training?
This is
So basically.
Residency.
Postgraduate residency.
Postgraduate residency, okay.
Daisy?
I'm just curious, how many residents does that support?
That's a good question. There is, within the formulary by which they analyze the need here, those numbers are a factor, I believe. I do not know what that number is right now.
That's probably a question for the medical center.
Yeah.
I think part of the, is not just salaries, it's also curriculum development and other kinds of things.
So it could be a continuing, you don't have to answer that, I'm just.
I don't know.
Very interesting,
Yeah, I don't know,
because it sounds
Daisy.
like a great
Representative,
program.
thank you for the question. Tomorrow's the budget address, so I think we're all gonna be surprised by that.
We're all anxiously waiting. So any more questions before we move on to 7? Art?
Just a quick one. So the $8 million here, we won't find it on the sheet?
No, within any global commitment appropriation, there is a state fund impact to that. No, that comes from the FMAP formulary that AHS provides us. Yep.
Okay, thank you.
And really what that request is about is enhancing our global commitment spending authority by way of this request so that we can access those funds.
All right, so number 7.
Okay, so I'm gonna do a quick overview here. There's a reason that we're driving from the narrative here is because, like, as I said at the beginning, everything runs numerically in ascending order. We've got several Brattleboro retreat items coming up here in 7, 8, 9, and 10, I believe it is. Yes. So we've got 4 items listed here, is essentially 3 functionalities, so bear with me. But we did 4 because we wanted to make things transparent and break it out for you all. But I'll start here at the top. So number 7 is an alternative payment model year 2 appropriation shortfall. So when the budget was passed, not enough money was originally budgeted to cover the full extent of that agreement as it was when the budget was passed last spring. So what we're doing is we're requesting $3.6 million gross here to cover that gap, that spending gap that we have. Yes.
Does that mean more beds are open and therefore there's more utilization? Is there a relationship there?
I think this shortfall is related to the lack of ability to open beds because of the funding shortages that they were experiencing at the time.
So what you're saying was that the funding level had to do with the number of beds, therefore they opened beds, so the shortfall is that gap between the old numbers and the old number of beds and the new number of beds?
I think this will all come together.
Okay.
If we could.
Let's get through all of the Brattleboro ones.
It'll become more clear how this all plays together.
Okay.
Sorry.
Yeah, that's fine. We'll come back to you.
Great question.
And so that request there is based on the original alternative payment model agreement for year 2. Now I should highlight for you because it's going to become important in the next one that their alternative payment model contract ran from January 1, 2022 to December 31st. So it's on a calendar year basis. Of course, we have all this wonderful interaction on a state fiscal year basis, so stay with me here.
Okay.
So the next one is where it begins to get complicated. So there was a need after reviewing Brattleboro Retreat finances and discussions between AHS and the retreat. The need being that the Brattleboro Retreat could not sustain itself based on that original year 2 contract. And number 2, the state needs critical access to mental health and inpatient care beds that the Brattleboro Retreat can supply for mental health care. And so contract negotiations opened up to try to rectify that and deliver to both parties continuation of services that are critical to the state. And so what that resulted in was a contract that was signed last fall, but retroactive to July 1st. So that's the beginning of our state fiscal year. But that is 6 months into this APM year 2 contract. So you can see by my little visual here that we're looking at the last half of APM year 2 and the financial impact of 9.38 million. And we're looking forward from January to the end of our state fiscal year for the first half of their year 3 contract, which I believe is now in place with the same terms. And so that impact is going to be 9.384 additional dollars. So for the state fiscal year that we have under that blue umbrella right there, the impact for purposes of our request here is $18.76 million. And what that is we're enhancing the per day rate from $2,550 to $3,100 and increased access to Medicaid beds from 42 to 51. So there's a need on both sides to make this work for the state of Vermont and for the Brattleboro Retreat. And so that's the sum of this request that's here before you as it relates to that organization.
Okay. Do we want to go through the next 2 or stop there? You tell me, Patrick.
Oh, we can stop there.
Okay. All right, Leslie.
I'm just curious about what sort of the standard rate for a psychiatric bed is. Is the standard 3,100 in the world? Do we know? Like if you went to another state or, went to another psychiatric hospital?
I do
I
not.
think there's a lot of variation in price and cost. I think in this case, the analysis was done to be able to open more beds and also provide some financial assistance to the retreat. Again, they do hold the only child and adolescent beds in the state. So it was.
Yeah, and I know they had real problems with travelers and COVID.
That's right, we heard that as well.
Yeah.
Yep.
And Leslie, you'll find that there's variation in these prices just within the state of Vermont.
Oh, yeah, that's what it seems like a big number, and I was just curious.
I just, maybe I missed this, I'm sorry, but what was appropriated in FY23's budget for this to begin with? What was the total appropriation?
For the retreat?
For the retreat. Now it's 18 million more.
Oh, I do not have the answer on hand, but we can figure that out. As stated in the ups downs, the way the state of Vermont budgets is based on the change, not necessarily what the base is. So we can go back and find that out for you.
I'm just wondering how big of a change.
Yeah, I'm thinking the same thing.
And I also want to just loop this back to a conversation we had yesterday in regards to the Department of Mental Health and the youth and patient beds, when there was a question of what state dollars are going to private entities, right, to help. So why would we be potentially giving $9 million to a hospital to help fund beds? This is a perfect example of another place in the state that we do that and have done it for quite a long time. So that's, sorry, outside of our conversation, but it's a good, loop them all back together. Okay. So number 9.
Okay. So number 9 and number 10 are separated out because of the movement of money, but they are completely related. So number 9 is a funding shift to GC. And what's happening here, as you can see in this little blurb that we have here, is that Centers for Medicare and Medicaid, CMS, has ordered a phase down of a funding source called the Institute for Mental Disease investment dollars. We have an 8-year runway to phase these dollars down. So what you're going to see on the ups downs here is you're going to see money moving out of the investment GC column, and it's being reallocated to other places on the ups downs document. So this first component of this is we're moving $4.6 million out of that investment dollar column and into global commitment. So from the perspective of our budget, there's no change. It's moving from essentially one federal source to another federal source. The second component of that is a funding shift to GF. So again, we are shifting dollars from that investment column over to general fund. And what we have here is a shift into GF from that federal source. So in looking, I'll use this opportunity to grab the ups downs real quick because I think it will help.
And just while you're doing that, this is a requirement of the federal government for us to phase down using global commitment funds on Institute for Mental Disease investment dollars. Again, we really have no choice here.
Yes, that's correct. So right here in the investment GC column, we have the sum total of the dollars that are coming out. You can see there's 4.96 million coming out of there and going to GF. That's one step. And then up in this appropriation here, it's coming out of this state-only GC column and moving up into Medicaid global commitment, pure global commitment. So it's a wash from a gross perspective overall. There is a state fund impact as we shift over to general fund dollars from that IMD money. Clear as mud, I know.
What's the difference between the Medicaid Global Commitment Fund and the Investment Global Commitment Fund?
I believe the Investment Global Commitment Fund, which resides under state only, means we have a larger amount of control over those dollars.
That's correct.
From a state perspective.
Great, thanks.
And it, correct me if I'm wrong, it's, if you remember when we had someone in talking about the new global commitment waiver, the investment dollars, the agreement we have with the federal government and the waiver is that we have investment dollars that we can use for things, and that's, I believe, what this fund is, correct? Yeah. So just to tie it back together. So I didn't say that as well as Patrick would have said it.
I don't know. Took me a little while to get my head around this.
You could potentially think about it as moving from investments to program.
Yeah.
But the notion of investments in this context is not what we generally think of as investments.
I know.
That's complicated.
It's confusing.
It's very confusing. I mean, it's actually program.
Right,
Moving
but
to
it's,
global commitment would be the program pieces. But we would probably go to the weeds with this really fast,
Yeah.
but.
That was hard.
it's hard to,
Investment dollars are flexible. You can use them for various things, but Medicaid dollars, global commitment dollars are very fixed. You can only use them for certain things. But
Joe?
Just wondering if there is a PDF somewhere that might explain these different funds.
Talk to Nolan.
Nolan, great.
Good source.
What was that?
Talk to Nolan. All right, number 11.
Okay. Medicaid rate adjustments. These are federally required rate adjustments that are occurring specifically within federal qualified health centers, rural health clinics, and hospice services. The gross amount here is $342.7 thousand. There is a bit of a cross appropriation activity happening here. The bulk of it is in global commitment. There is a much smaller amount occurring within the non-waiver, but you can see that it's aggregating up into that total. These went into effect January 1. And again, this is a federal obligation that we have to enhance these amounts. This is just for the last 6 months of this fiscal year. So that's why the number is so small.
Okay. Any questions? Okay.
Okay, we are getting into the home stretch here.
Yeah.
Performance year 2021 ACO settlement. Yes, we are in 2023. That kind of highlights how long it takes to reconcile the activity from the performance year as it relates to the state's accountable care organization, OneCare Vermont. And so what this request is for is to make a payment to OneCare to pass down through what they call the risk-bearing entities, which are the state's community hospitals that are engaged in the Medicaid component of the all-payer model. So the reason that the state has this contractual obligation to pay out $7.18 million is because there is a target amount of spend that is agreed upon between the state and the ACO. On either side of that target, there is a thing called a risk corridor. It's plus or minus a certain percentage. If OneCare underspends that target, they are owed money for that underspend because they are theoretically saving healthcare dollars by underspending that target. If they overspend, then there's a punitive component where they collect money from the risk-bearing entities and they pass it back to the state to cover for that overspend. The theory there is that it encourages hospitals to operate efficiently under that construct and mitigate the cost growth or bend that cost curve that you're going to hear so much about. That risk corridor piece limits or mitigates the liability of each side, because if they were to overspend and we were to hold them 100% accountable for all of that, they could go. We could do some serious damage to the healthcare system. So there's a risk corridor there that caps out what either side would have to pay to the other based on the activity for that year, the underspend or overspend on the target. So this year, through the reconciliation process that they arrive at on an annual basis, OneCare underspent. The amount of that is owed back to them is the $7.18 million that we have in front of us here for performance year 2021.
Art and then Alyssa.
Was any money ever put into that bucket in the budget, or do you leave it zero and hope for the best? I mean, or go by history and.
I don't think they allocate for it on an annual basis. I think this is the vehicle by which they deal with the potential payment.
Okay, I didn't know whether.
But I'm not 100% positive.
Okay, I didn't know whether they looked at history and said, well, throw 5 million in there in case. I don't know, whatever.
So remember that they have a contract of what the spend will be. And then if they're over or under that spend, this is where this adjustment.
Correct, but
yeah,
if history shows that they're always under by a certain amount, I mean, why not throw in 5 million and let all of us know what it is and we can.
Right. Well, and I think part of it is based on the population. So every year the population that they're covering through Medicaid changes. So the risk changes for that population.
Okay.
Yeah. Plus, 5 million would be a number just to throw in.
Well, it was sort of to the same point, was why not just budget for it? And then if it turns out they owe you money, then we get it down instead of an up, or an up instead of a down.
And I think we have had a down.
But I was just thinking, I think last year, the ACO owed, I think it was last year.
Was it last year? I don't remember.
Year before, yeah, pre-pandemic
Yeah.
reconciliation.
Yeah.
Because in 2020, there was so little use of healthcare
Yes.
that they
Yeah.
far underperformed that target. And so, and I should point out too, this is just Medicaid. Medicare has their own
Yeah.
Yes,
reconciliation.
we're not even going there.
We're not going to go there. I don't want to.
In that case, they over, right? And they're.
Technically, yes, they overperform, they underspend.
Underspend.
Yeah,
Right.
correct. Yeah.
Keeping people healthier. All right, I think we can go.
Okay.
Oh, Joe.
Sorry, quick question. And is that contract based solely, we've learned so much about ACOs. Is that based solely on spend, or is that based on quality metrics and outcomes? Both. Great.
Great question.
And so before we move on here, again, you can see the bulk of this is global commitment related dollars. There's a small portion in non-waiver. It does have a small cross appropriation impact to the budget. And closing out here, there's that word again, carry forward. These are dollars that were left over from the prior fiscal year. We did have a reasonable expectation that the caseload component that we really dug into here a short time ago was going to have a major impact on our budget moving forward. So there was some dollars that were left over and therefore reserved for carry forward for exactly this to help offset that request in number 4. So we do have these dollars which are suppressing the overall need there by $1.9 million gross, because we pretty much knew this was coming, and we don't know what we don't know when it comes to public health emergency. So
We all learned a lot.
that's right. Still learning.
Still learning.
That rounds out DIVA's 2023 budget adjustment requests.
Just in time, Nolan. So one, this was very informative and very clear presentation, so thank you for that. Two, it's, for those of us that are new to this, normally with the DEVA budget, there's very little impact for us. I mean, these are contractually required funds, caseload utilization. I would love to get more information on number 3, the data warehouse. And I know I'll ask a couple other questions, but these are big numbers, but it's big numbers that we're mostly hired to do.
Your end of year reconciliation, how much do you utilize MMIS or your, whatever the new acronym is? Do you use that database?
For the ACO? Is that what you mean?
Yeah, when you do your end of year reconciliation.
We use it a lot. In terms of the claims analysis, yes. That's all fact. That's how we gather our gather our data, and then the ACO from their side also gathers their information, and then we reconcile. We work together to reconcile and come to an agreement.
Do you think that is there a potential for some cost savings or ROI on that investment if we approve that expense of is it number 3?
Oh, the MD-WAS?
Yes.
So I actually think, just from my perspective, that having claims and clinical information together provides a great picture. And so, yes, I think there's improvements that we all could benefit from having that information available in one place, one source of truth versus 5, however many there are now. BCures, MMIS, other kinds of, the VHI is another repository.
So I have a question, Nolan, if you don't mind me putting you on the spot, because you might be able to answer this since you have the most history in this room. So we have been discussing the 5.8 million request for the Medicaid data warehouse and analytics solution. And I remember in the past budgets, funding for IT transition, and I am trying to determine if this is a continuation of what we've done in the past or something new, do you know?
Having not had a chance to dig into that.
Okay, that's fine. Okay.
Don't know.
So you'll get back to
This
us.
does tie back, and this is sort of jogging my memory, but this does tie back to HIT fund and the expiration of the HIT fund and our shift in how we have done the work over time.
Okay.
So it's all related. I think this acronym is new, like a brand almost. It's like the state, these acronyms become words. MD-WAS. So I think we could probably provide a better explanation.
That would be helpful.
To you in an email or.
Okay, that's great.
And then that will help tie it all together.
Okay. Alyssa, Art, and then Jen.
So, just because I feel so personal about this, Act 48, which was the IHIP. So originally in FY '22, we had appropriated state-only dollars of 1.4 million as a grant program. And then FY '23, 1.4, and the program was supposed to be put forward and using state-only dollars. How much of the original 1.4 was given in grants, and if not all 1.4, where is that money? And shouldn't it be in budget adjustment if it wasn't used? And I'm not going to speak to the 1.3 or the 23 because I'm assuming that it would just get rolled into other programs, but specifically that FY '22 money.
Yep. So I don't have an exact figure for you on what we spent to date. It is much lower than the amount that was allocated and resides in our base budget. This program has taken on quite a different look even in my time here. The claims were being processed manually up until July. It is now moved into, I believe it's the MMIS system, so it's electronically based. And because of the nature of that program and getting out the word about what this program can do for people, it takes time to ramp up. So we are really underspent right now on that money, but very hesitant to come in and ask for a downgrade based on what could happen in the ramp up of that program.
No, I mean, I just specifically was talking about the 1.4 from 22. Because the grant, that was all it was used for, it was for the grant. So
But
how
that
much?
was, but that was helpful.
Yes, that is very helpful,
But I
but
don't know. We
how
can
much
get back
was
to you.
given out in grants and how much was left over?
We can get back to you on that. Yep. That predates my time, so I'll
Okay.
have to look into it. Yeah.
Thank you. Art?
Yeah, I just wondered if you folks, and I think we might have asked this before, but is there a way to produce a document that shows line by line what we budgeted and now what more is required or less is required, so that we get a sense of how we're doing in the budget and then show all these numbers down at the bottom? I get confused because this is the change, right? For the most part. And it's in a format that it just, to me, it makes it hard.
So you can see up here at the top in the original line, we have DIVA appropriation as past 23. So for general fund in our appropriation 306
Okay.
administration, it's the base budget is $34.6 million.
Okay. For everything. Or
Just for the general fund piece.
Just for the 306.
Yes, and just for the general fund, that source and
Right,
use up at the top.
right.
And so it works like
That's
that.
really what I care about.
Yep, it works like that all the way across. You can see where the base
Okay.
budget lies. And then all of the interceding activity here determines where that
Okay.
requested budget is going.
So the difference at the bottom from what's at the top, so 34,666 as compared to 38,730 is the difference we want in each one of these categories.
Correct. Yep.
Okay.
And then all the way across, aggregating in a total down the right-hand side. So you can see that your total administrative base budget for 2023 as passed was $163.2 million. We are requesting $5.86 million right there. And so the proposed new budget, if approved, would be $169 million for administration.
Okay.
And so what these are doing is they're showing you what's driving that total on the far side.
Okay, I guess that suffices. Thank you.
Yeah, like I said, it's taken me a few versions
Well, that's the thing.
to get
You
through
gotta
that.
look at this a lot to really get it.
The DIVA budget, to be honest, is pretty complicated.
Oh, yeah, no, I understand. It just, you want to see what you're doing.
Nolan wanted to
I
comment?
was just going to comment that, for the record, Nolan Iola, Joint Fiscal Office, the whole budget uses that document. And for every agency, or these three HS, and I think that once it's confusing at first, but once you get it, it makes complete sense and you don't want it any other way. And two, on top of that, DIVA, in my opinion, does the best job of any agency coming in and doing a narrative. With the handout narrative, no other, well, DMH did it this year too, but DIVA's been doing it for years. So to their credit, they're one of the cleanest, because it's so complicated, they do an excellent job of clarifying, so.
Thank you, Nolan. Joe?
I know we're going to be getting more information about MDWAS, so I'm not expecting an answer to this right now, just included in the information we get. But you mentioned that one thing that MDWAS will be doing is combining clinical and claims data. That concerns me from a data privacy standpoint, a patient privacy standpoint. So I was wondering, in the information you give us, if you could also give us a little bit about how that information will be used, number one, and number two, how when there's clinical data, since there is clinical data involved, how patient privacy will be protected in that, both from sort of general, like unauthorized access, but also from like cyber attack and things like that.
Okay. We can provide you with what's available to us, absolutely.
Thank you.
And also how it would be obtained. How is the clinical data being obtained? That's all.
Yeah.
If you can add more stuff.
And I'm just going to say, we do not need that before we need to make a budget adjustment recommendation, because that's a bigger ask, I think. So just if you could get it to us in the next couple of weeks would be great. Joe, is that okay?
It's fine with me.
Leslie?
Just a process question. So the BAA, when is that done?
So we will continue taking testimony tomorrow, specifically more on the Department of Mental Health side. And I have blocked, Claire has blocked for us all of Tuesday afternoon to have a discussion. And then we will need to make a recommendation to House Appropriations by the end of day Tuesday.
By the end of the day, so we gotta be done by
Tuesdays.
Got it.
Fast.
Okay,
Yeah.
that changes things a little bit.
Yeah, it's fast, it is fast. And then remember, the governor's budget is tomorrow, so we'll all be anxiously awaiting that address.
And then just to finish, so then it goes to appropriations, and then when is it out of appropriations?
Oh, I don't know the process after that yet, but it'll come out of appropriations, we'll vote on the floor, and then it goes over to the House, Senate, and starts all over again. Yep, great. Thank you both very much. This was a.
Thank you.
You're welcome.
Thank you.
Budget?
It will be done for today, and we'll be back here tomorrow.